to the Excimed company for inviting me, and thank you for all of you for staying. It's been a long day, and I hope we can share. I'm also learning from other surgeons as well. Well, I actually started somewhere in 2022. I started off my refractive surgery journey as a LASIK surgeon, and I do notice that there is a gap in where there are some patients who are not fit to go for LASIK surgery. Then I had to offer something else, especially those with a thin cornea, corneal scar, and also those with a very high refractive error. So my first patient was this young boy. At that time, I think he was about 18 or 17. His refractive error was still unstable. It was about, I remember it was more than 10 diopters. So I made a promise to him. His name is Daniel. I said, Daniel, it's okay. Next year when you come, once your refractive error is stable, I will implant the lens for you. So indeed, he came back after a year. Then I managed to implant, and since then, with the support of Siva, who's always been by my side and make sure that things are okay, I have implanted about 280 cases. The Phakic IOL that I implant is just the IPCL. I don't implant other lens. So yeah, next. I want to show you a video of how I implant the lens. So first, this is how we load the lens, something like what Dr. Yip has shared before. The orientation is very important, so take time. I usually load the lens before the surgery begins. Then I make one paracentesis wound, then I inject the lignocaine and fill the OVD about one third. And the incision is 2.75 but slightly extend. Yeah, the slow injection is very important. Yeah, and sometimes we can't predict of how it will load in the eye. Then maybe you can pause here. Okay, what I noticed for the easier implantation is that I tuck in the notch first. So there is, when I first started, I found it difficult to tuck in the haptic because I don't have the second instrument to help me stabilize the lens. So I found a way that, what if I tuck in the notch first? Okay, so I tuck in the notch first, then only I can fold the, I call it the ears. Same goes. You see there's a notch in the middle. Then we can gently tuck it in. Yeah, okay. And I prefer to remove the viscoelastic with manual irrigation. I started off with doing with the IA, but then I find that patients were uncomfortable when I insert the IA probe, even with the low bottle height. So I thought, okay, why not I just try using a 3cc with a slowly, gently flush, because we do not want to sudden decompress the AC, which could lead to other complications. Okay, next. So the principle that I go is we measure twice, we implant once. And that we want to choose the right size, because incorrect size can lead to the vault to be improper. Vault basically means the space between the IOL here, the space between the lens and also the IPCL and the crystalline lens. Ideally, it should be about 250 to 750. Okay, next. So in cases when the vault is very high, so you will see it at the slit lamp that the lens is bulging forwards. This can cause the IOP to be elevated, and the patients will also complain of, the vision is not clear. And in the long run, it can cause the rubbing on the iris, which can lead to pigment dispersion and chronic inflammation. This happens usually when the lens is too big. Okay. On the other hand, if you have a low vault, the low vault means that the space is less than 250. So the lens IPCL we touch, there's a risk of it touching the lens, the natural lens. So it leads to formation of cataract, and the patient can also have a visual distortion. So I think it's been covered by Dr. Yip as well. So the measurements that we take, I just want to say, actually for you to start off, it's very simple. I think most of us, we can just buy a caliper. We do have, some form of biometry regardless of whatever the company is. So we just need two. Ideally, the more the better, so that we can validate between each of the reading. But you take the digital caliper and the optical biometry, and if you are lucky, you have the UBM, you can also measure the sulcus to sulcus, but the S2S value is also operator independent, which means from one person to another might give a different value. Whereas the IOL master, it's higher reliability, so we can use that. And for the internal AC depth, we measure it from the endothelium, which means that the AC depth that you get from your biometry, you minus it off from the CCT, or the central corneal thickness. So then you get the internal AC depth. So the way to measure the caliper is from the surgical limbus, which is at the edge of the cornea, just about to turn blue. That's why you measure it. Now the challenge here is that I agree, when the practice is busy. Number two, sometimes patients on the first consult, they don't seem interested to go for the IPCL, so I don't measure them. And then the next time they come in with a deposit, the patient is not there. So what I do now is, I just try to measure everybody as much as I can. And it can be a bit scary for the patient when they see, like a sharp tip instrument going close to their eyes. So I bought something from Siva that the caliper is tilted downwards, so that the patients don't actually see it. So that has been helpful. Okay, next. So it's been shown that reading, like the IOL master, tend to overestimate as compared to the caliper. It's usually smaller, so we can always compare between them. Okay, I also want to share with you one of the few cases, in case all of you are wondering, how to start. The journey gets easier from time to time. I do admit this is one of my first few cases. I think not even 10 cases, yeah? A 33-year-old Indonesian lady. She had very high myopia and also high astigmatism. So she wanted to ditch her glasses. So I implanted her with the IPCL. Her white to white was 12.3. On the left side is 12.4. The left side we put the size of 132, and the right side was size 13. So on the post-op day 1, okay, the left eye is good, 6, and 3, so I will focus on the right eye. She had 620 and N4. So I thought, okay, never mind, we'll just review after 1 week, because maybe she's still adapting, there's some inflammation. So then after 1 week, the right eye still remains, that poor vision, 615, so I dilated her eyes and noted that the IPCLT was actually rotated upwards. So I decided, okay, let's just dial the lens. I dialed the lens. After 1 hour, she was good. Immediately, she was happy, and then I sent her home. And then the next day, she said, about 4 hours after the surgery, her vision became blurred again. So I decided to change the size. After a few weeks of getting the new size. Okay, and also I want to show that the vault was good. It's within the normal range. Yeah, so we changed the size to 13, we upsized, one size higher, 132. Then she ended up with a good vision, and eventually she reached almost plano and 6 and N3 vision. So learning from this case, we could see that although the vault is normal, but it doesn't mean that the IPCL is stable. So we do want to check all of this as a whole. And then when you dial and it rotates again, clearly it's most likely it's undersized. So if you want to, like the metaphor I tell my patients is that it's like you have a big space, then it's easy for something to move around. And so yeah, we can upsize. And in terms of sizing, just in case some of you are thinking that it's intimidating to tell the patients. Patient might get upset. Didn't you measure my eyes? How did you get the size wrong? Well, I give them analogy. I ask them, okay, this happens during counseling, pre-op counseling, so that they know what to expect. I tell them that, how we buy clothes online, we take a measuring tape, we measure, but when you put on the clothes, once the clothes arrive, it's not a perfect fit. So it is just like this. We have done, I will tell them how much I have measured and everything, but we just see how it is once it's really inside the eyes. And of course, with more experience, you have your nomogram, then things will be more stabilized. So then if you get an IPCL rotation, do you rotate or you exchange? So I usually look at the vault. If the vault is not normal, then immediately I contact the manufacturer to upsize. But if the vault is normal, I attempt to dial, and I have a few cases in which I dial and they remain stable. But if it recurs again, like the case that I shared just now, then I will change the size. Okay, on the other types of post-op complication, yes, corneal edema can happen, especially when the lens opens up in a way that is unexpected, that it touches the endothelium. And also just be mindful of these high myopic patients. They tend to be steroid responders, so we want to taper the steroids fast and add in anti-glaucoma if needed. And the other is the early complications, such as early rotation. This one we can dial, or like what I explained earlier. And most patients will also most patients will also complain of this, where they have dysphotopsia. So you just reassure them. But I just want to say that these patients, the high myopic patients, they are the best patients, because they are starting from counting finger vision. When they get up in the morning, the first thing that they reach for are their glasses, and then suddenly they can see well. So in general, they are not the picky patients. So, but of course, they will say at night they have all this glare and halos. So we and also it's important to highlight on the dry eyes. Okay, I also want to say that on the IPCLT rotation, I have had 2 patients. After 6 months, they came with the IPCLT rotated, and both of them had very high impact activity. One of them was a girl, she does taekwondo, and the other one was a boy, he likes to play futsal. So I dialed the lens again, and I advised them that maybe they want to look at other sports to fulfill their needs. And the other ones, okay, if they have persistent dysphotopsia, again you want to address the dry eyes. And cataract, you just manage. If it's visually significant, you can remove the cataract. And the glaucoma, this is one of the things that I really I'm very worried about. But so far, alhamdulillah, things are going well. But it's important to monitor. The minute you see that the vault is high, then maybe it's time to change to a lower size. So this is my post-op routines. The thing is, when the patient has this implant, I don't discharge them. They will stay in my clinic. I will see them every 1 year to make sure things are okay. And recently, one of my patients, during consultation, she just met with somebody. And then I implanted the IPCL just before she got married, and now she has a baby. Then I said, next year when you come, maybe it's the second baby. So we actually grow together with these patients. So on the first 2 hours post-op, just monitor their IOP. Sometimes I prescribe them with Diamox about 250 BD, just to ensure that the IOP is stable. Then the next day, I review them for the visual acuity and also the IOP. Then week 1, the same. And at 1 month, that's when I check for their refraction. But of course, if you see that the vision is not 6/6 by first week, something is wrong. Okay, next. Okay, so in summary, remember to measure twice. And then sizing is very important, and monitor your patients closely. Thank you.